I want to welcome Dr. Christopher Popa to the Baltimore County Fire Department EMS Academy Training Series. Dr. Popa is a retired colonel from Walter Reed National Military Medical Center, previously Walter Reed Army Medical Center, where we both worked. He graduated from the Uniformed Services University of Health Sciences, also in Bethesda, in 1994, and completed a transitional internship at Madigan Army Medical Center, which was in Tacoma, Washington. He then did his anesthesia residency and critical care medicine fellowship at the Walter Reed Army Medical Center, where he remained to this day as staff, becoming the chief of critical care and the program director for critical care medicine in the military at Walter Reed for their fellowship. Additionally, Dr. Popa is an examiner for the American Board of Anesthesiology, and he's coming to us today to present one of the topics of interest, which is shock. His other interest basically is cardiac anesthesia and respiratory physiology. So without further ado, I'd like to welcome Dr. Popa. Welcome, Chris.
Thanks, Jeff, and good evening, everybody. Let me know if you guys can't hear me or if we have any trouble with the slides. We're going to keep this fairly informal, so if there's questions along the way, please ask, and I'll leave a little bit of time at the end for questions as well. So without further ado, let's talk about shock. Once I figure out how to advance my slides. There we go. So our objectives, we're going to define shock, and we're going to talk about the different types of shock, some of the specific treatments, and also an approach overall to a hypotensive patient. So we'll start by defining shock. And the important thing that I want to get across is that the definition is a clinical one. There is not an absolute number that defines shock, and different people will tolerate different blood pressures and oxygen delivery rates more or less well, depending on their physiology. But we define shock as inadequate blood flow, i.e. oxygen delivery, to meet the body's metabolic demands, resulting in widespread ischemia and anaerobic metabolism. And the resulting tissue hyperperfusion results in a progressive metabolic acidosis, which leads to further decrease in oxygen delivery and a malignant positive feedback loop. It's important to note that shock can occur even with a normal blood pressure if, let's say, the forward flow and cardiac output is insufficient to meet the metabolic demand. And hypotension can occur without shock. Somebody with a blood pressure of 70/50 may be asymptomatic and perfusing relatively well, while a different patient with the same blood pressure will be obtunded and in obvious clinical shock. But ultimately, the diagnosis is clinical. So what will you see? You will see signs of inadequate perfusion. The body's going to vasoconstrict to try to maintain flow to critical organs. So the extremities are typically going to be cold, paled, poor pulses, and mottled from stasis. As you activate the sympathetic nervous system, you're going to see inappropriate sweating, i.e. they're going to feel cold and clammy from the vasoconstriction and yet sweat from the adrenergic activation. You'll typically see large pupils, regardless of the ambient light. You'll have oliguria. You will see a worsening and progressive lactic acidosis as you get more and more anaerobic metabolism, altered mental status fairly early since the brain has a high oxygen consumption and demand, and tachypnea, nausea, and vomiting as the GI system is affected. So all of these are manifestations of a patient in shock. Now, as you have inadequate systemic oxygen delivery, you will activate the autonomic nervous system to try to improve and maintain that delivery. So the body will release norepinephrine, epinephrine, dopamine, and cortisol, and this will result in tachycardia and increased contractility to try to raise cardiac output, vasoconstriction to try to maintain blood pressure and perfusion of core organs. And with that, you will have activation of the renin-angiotensin-aldosterone axis, which results in water and sodium conservation and further vasoconstriction. All of this in an attempt to increase blood volume and blood pressure. And this is the compensated phase of shock. Unfortunately, because there's still insufficient oxygen demand, over time, this leads to progressive adenosine triphosphate depletion. And as cells run out of energy, you get ion pump dysfunction, at which point you lose the ability to regulate intra and extracellular ions. You get progressive cellular edema. And at some point, you get hydrolysis of the cellular membrane and cellular death. And cellular death leads to multi-organ failure. And in an attempt to maintain cerebral and cardiac perfusion, you'll vasoconstrict everything else, notably the splanchnic and renal and musculoskeletal blood flow. And this again leads to a worsening systemic metabolic acidosis that overcomes the compensatory mechanisms. And as shock continues to progress in the decompensated stage, you now get cardiac depression, worsening respiratory distress and need for mechanical ventilation, renal failure, liver injury, and DIC. So all of this results in sequential end organ failure. And one concept from critical care is that there's roughly a 20 to 30% mortality per failing organ system. And obviously, it doesn't take very long for shock to become fatal if this process is not corrected. So think of shock as having three phases. There is initial compensated phase from activation of the sympathetic system. There's a decompensated phase as you get worsening acidosis, progressive myocardial and respiratory depression, and worsening hypotension and hyperperfusion. And the problem is when this process goes on long enough, it becomes irreversible and those organs and the body is no longer salvageable. One concept you guys are familiar with is the golden hour of trauma, and it sort of stems from this irreversible phase of shock. Beyond an hour, even though you may be able to put the patient on pressors to restore blood pressure, you may be able to transfuse to get the hemoglobin back up. It's basically too late and the patient is ultimately going to expire. So shock is an emergency and treatment is time sensitive regardless of the cause of shock. There are four basic classifications of shock that we can divide the etiologies into. So cardiogenic, hypovolemic shock basically result in insufficient forward flow and insufficient cardiac output to perfuse the body. So cardiogenic shock involves pump failure, and you can get that from ischemia or myocardial infarction. An acute loss of more than 40% of the myocardium is enough to throw somebody into cardiogenic shock. Arrhythmias, especially if they're fast enough to where they don't allow filling. And myocarditis, myocardial contusion, or cardiomyopathy, where you lose enough contractility to not have forward flow. With hypovolemic shock, and you can have either hemorrhagic or non-hemorrhagic. The pump, the heart itself is working fine, but there's not enough substrate to pump around. So as a result of that, cardiac output falls and the body's unable to be perfused. Hemorrhage is a fairly obvious cause, but severe burns and fluid sequestration, pancreatitis, severe dehydration with loss of more than 40% of volume will result in rapidly developing decompensated shock. Distributive shock is a little bit different. We also refer to this as hyperdynamic shock. And here, even though the patient has adequate pump function and adequate blood volume, there's inappropriate vasodilation, and with that, usually a developing capillary leak to where fluid leaks out of the intravascular space. And as a result of that, there's a very low diastolic blood pressure and an inability to efficiently perfuse organs. So typically here, the systolic blood pressure is normal. The diastolic blood pressure is very low. The pulse pressures widen, and at least in the initial phases, the patient is hyperdynamic and they're going to have bounding pulses, warm extremities, etc. However, they will have insufficient oxygen delivery. So sepsis is the classic version of distributive shock, but you can also see this with anaphylaxis. You can see it with high cord injuries and neurogenic shock, where there's inappropriate vasodilation below that cord level of injury. You can see it with drugs. You can see it with something like diphtheria toxin. You can see it with thyrotoxicosis, and you can see it with adrenal insufficiency. These are all forms of distributive shock. Um, Obstructive shock is worth noting and putting a little bit of emphasis on, because here, even though there's adequate blood volume and adequate pump function, something is preventing the heart from making blood efficiently. And these are all specific causes that are reversible with specific treatment, but can become rapidly fatal if they're missed. So things like tension pneumothorax, which basically blocks venous return to the heart, a massive PE, which obstructs circulation, or cardiac tamponade. These are all forms of extracardiac obstructive shock. So we have cardiogenic, we have hypovolemic, we have distributive, and we have obstructive. These are your four options for shock. You can look at the hemodynamics to get a little bit of an idea of what you're dealing with when you are trying to make a diagnosis and troubleshooting. So remember that even though shock is not dependent on a specific number for blood pressure, most shock is associated with hypotension. And blood pressure is a function of cardiac output and systemic vascular resistance. So sometimes you're unlucky and it's both, but usually one or the other is low, which can point to the etiology of the shock. So systolic blood pressure is determined by contractility, and that is a function of how well the heart is pumping and also of the preload available to pump. And diastolic blood pressure is determined by vascular tone. These people that are inappropriately vasodilated, i.e. sepsis, will achieve a normal systolic blood pressure initially, especially with fluid resuscitation, but have a very low diastolic because they have no vascular tone, and overall a low mean arterial pressure. Normally, we're at about 50% vasoconstriction in terms of normal vascular tone. And that's what keeps your diastolic blood pressure at 80 when the heart relaxes, as opposed to the left ventricle end diastolic pressure, which goes to 0. If you have an A-line in place, and you can do the same with a pulse oximeter or just simply feel the pulse, you can assess the pulse pressure. So somebody that has a cardiac or hypovolemic form of shock, because the heart is not pumping efficiently, they're not going to achieve a very high systolic, and that's going to be lower than normal. The body is going to compensate by increasing systemic vascular resistance and raising the diastolic blood pressure. And as a result, they're going to have a very narrow pulse pressure, a low overall blood pressure, and a lower than normal systolic with a higher than normal diastolic. And that person has a forward flow problem, be it preload, be it contractility. Somebody that has a high systolic, low diastolic, widened pulse pressure, and sort of bounding pulses has a hyperdynamic version of shock, sepsis being the most common, but can also be things like endocrine deficiency, allergic reaction, or something along those lines. Another thing that's useful, and again, you can do this off an A-line and you can do it less well off of pulse oximetry tracing, is look at the respiratory variation. And that has to do with the fact that changes in intrathoracic pressure with breathing affect right ventricular volume. And since the right ventricle and the left ventricle share a septum, every time the right ventricle has increased filling, the left ventricle has a little bit of decreased filling and vice versa. And basically that translates into a respiratory variation in the peak systolic blood pressure that's achieved. If somebody's hypotensive and if they're hypovolemic with low filling pressures, then those respiratory changes get accentuated and you'll see a more than 10% variability. And that correlates with volume depletion in somebody that's hypotensive. So you are likely to see that if somebody is bleeding out or if they're dehydrated, et cetera. The other thing that's worthwhile to look at is this dicrotic notch on your tracing, and that represents aortic valve closure. And basically that happens when the heart finishes ejecting blood at the end of systole. If the preload is low and the ventricle is underfilled, that aortic valve closure occurs earlier and earlier. And what you'll see clinically is this dicrotic notch, which is normally a half to a third of the way up on the tracing, will happen lower and lower on the tracing. Eventually the two will separate, and eventually you will lose that dicrotic notch on the tracing altogether. So again, this is another marker of hypovolemia. If there's minimal respiratory variation, that notch is relatively nice and high, then those are things that are consistent with an adequate filling status. So in terms of a very brief differential, for hyperdynamic, high cardiac output, low systemic vascular resistance shock, i.e. warm shock, early sepsis will show up like this. Anemia, because you're dropping viscosity and creating increased cardiac output to try to maintain O2 delivery, will do this. Anaphylaxis will do this. Thyroid storm will do this. These are all manifestations of a hyperdynamic type shock state. Cardiogenic hypovolemia and extracardiac obstructive forms of shock, where the heart is not pumping forward efficiently, are all going to present with a narrow pulse pressure, a low cardiac output, and a high systemic vascular resistance. And that basically implies a forward flow problem. So if you come across a patient, let's say they're acidotic, increasing lactate, minimal output in urine, tachycardia, narrow wide pulse pressure, pulse ox not picking up because the extremities are not being perfused, low systolic. Clinically, they're going to look ill. You'll see an altered mental status. The skin typically will be cool and mottled with a low cardiac output state. It may be hot and flushed if they're hyperdynamic. Weak or absent peripheral pulses, tachypnea. These are all manifestations of and signs and symptoms of shock. And this is what helps you make the clinical diagnosis, especially if coupled with, let's say, a low blood pressure in the appropriate clinical setting. So in terms of hypovolemic shock, again, we divide it into hemorrhagic and non-hemorrhagic. Common causes that you're likely to see, trauma is usually pretty obvious because the bleeding is going to be outside the body. And there will be evidence of trauma at the scene. GI bleeds can certainly cause hemorrhagic shock if severe. If a GI bleed is severe, regardless of ileus, eventually the patient is either going to have hematemesis or bright red blood per rectum. And usually if it's an upper GI source, which most of these are, and they have bright red rectal bleeding, that means that they've lost a minimum of a liter of blood, because they have to have enough of a rapid transit time for the blood to not be digested. So the minimum there is a liter. And at that point, invariably, they're going to be hemodynamically unstable. If they have bright red bleeding and they're stable, chances are that it's a lower GI source, hopefully less than a liter. Massive hemoptysis, postpartum bleeding for pregnant patients, ectopic ruptures. All of these can be causes of hemorrhagic shock. If it's not an obvious bleeding source in terms of internal bleeding, there's only a few places in the body you can bleed enough to actually result in life-threatening bleeding. You can put several liters of blood in your chest, and obviously you'll pick it up because you'll have decreased sat, you'll have increased, patient will have increased trouble breathing, they'll have dullness to percussion if you tap on them, they'll have absent breath sounds as that lung is being compressed. You'll see other clinical manifestations to suggest that. Peritoneal bleeding, where you'll have a expanding ecchymotic abdomen. The retroperitoneum is another place where you can bleed enough to bleed to death, and the most common cause there is pelvic fractures, usually at the scene of a motorcycle accident, car crash, or a fall, and then bilateral femur fractures. You can put about a liter of blood in a thigh before it fills up and there's no more room. So a single femur fracture typically will not bleed enough to put the patient in shock, but bilateral femur fractures, you can have enough blood loss to be in shock and be life-threatening. In terms of non-hemorrhagic causes, fluid loss from vomiting, diarrhea, bowel obstructions or pancreatitis, where you have translocation of fluid into the third space. Burns, you can see this very quickly. You can see this with heat exhaustion, and as it progresses to heat stroke, if somebody loses enough fluid from sweating. And then last, neglect and dehydration, if somebody is not given fluid to meet their requirements. These are the classes of shock for hemorrhage from ATLS. They divide hemorrhage into class 1, 2, 3, and 4, with 4 being the most severe. And it's worthwhile to look at this and some of the signs that you can see with the various amounts of bleeding to tell which patients are in shock and which patients are most at risk for and you have to intervene. So class 1 hemorrhage is less than 15% of total blood volume, and it's up to but not exceeding 750 mLs. These patients typically are going to be only mildly tachycardic, heart rate under 100. They will be able to maintain a normal blood pressure. They'll have either a normal or slightly increased pulse pressure from activation of the sympathetic system, very minimal tachypnea. They'll have low but adequate urine. They may feel slightly anxious. Bottom line is these guys are stable and are not in shock, okay, and they're not in acute danger at this point. They do need fluid replacement, and they can either take that orally or IV, but they're not in any immediate danger. Class 2 hemorrhage is up to 30% of blood volume, and this is in the range of 750 to 1.5 liters. At this point, they will become tachycardic. They will still have a normal blood pressure. Their pulse pressure will be narrowed, though, because they're going to start decreasing cardiac output. You will see increasing tachypnea. You will see mild oliguria. And again, they will be more anxious, but they will not be delirious or obtunded. And these guys are not in life-threatening shock. They're in compensated shock and will do okay, provided they're provided timely fluid replacement. Where it gets dicey is class 3 hemorrhage, which is beyond 1,500 mLs. Because at this point, you will have hypotension and a significant tachycardia over 120. They're going to be severely oliguric to anuric. You're going to start seeing mental status changes. The bottom line is if you have somebody that comes in with, a bleeding event and they're hypotensive, then that person is either in class 3 or class 4 hemorrhage. And they're going to need blood as well as crystalloid, and they're very likely to need surgical intervention. So those patients should go to a facility with surgical capabilities, and trauma surgery or the equivalent should be contacted early because they're probably going to end up in the operating room. Anything over 40% of body weight or more than 2 liters is imminently life-threatening and can lead to cardiovascular collapse. Here, you're going to have very severe tachycardia. You're going to have significant hypotension, very narrow pulse pressure, severe tachypnea on its way to respiratory failure, anuria, probably obtunded or unconscious. And these patients need immediate resuscitation with blood and probably an immediate trip to the OR to control hemorrhage. The other point worth making is if somebody's bleeding out, till you're able to establish surgical control, you want to resuscitate them enough to perfuse things, but you don't want to necessarily resuscitate them up to a normal blood pressure because they will bleed more and have higher transfusion requirements, and that's been shown to lead to worse outcomes, especially if there's going to be any delay in surgical care. So, resuscitate them up to, let's say, a systolic of 90, 100, whatever you think they need to perfuse, but you don't necessarily want to fully resuscitate them to a normal blood pressure until you can get the sources of bleeding controlled. So in terms of treatments, airway, breathing, circulation, in that order always first. If they are severely acidotic and severely hypotensive, they're not going to be able to perfuse their respiratory muscles very long, and they're likely to suddenly fail. So they probably will need a airway sooner rather than later. The other thing is if they have limited perfusion, you want to rest their respiratory muscles as much as possible and offload them through mechanical ventilation and allow them to other more vital organs. And then in terms of circulation, two large bore IVs are a central line for resuscitation. We'll talk about flow rates in a second, but large bore IVs, especially short ones, are going to be more rapid to establish and will give you adequate flow rates for resuscitation. Crystalloids initially. You can consider albumin, but even though it's a colloid and theoretically stays intravascularly better, it's viscous, so you're going to achieve much slower flow rates. It's also more expensive, and overall, there's no proven benefit. So you can consider it, especially if you have large bore access, if you're bleeding rapidly, if you're giving huge amounts of crystalloid, but for the most part, crystalloids are going to be the way to go initially. And then if somebody's in class 3 hemorrhage, if shock persists, if the acidosis is not rapidly correcting, if they're still bleeding and if the hematocrit is low, then they're going to need packed cells or whole blood if you have it available. In order of preference, if you have it, cross-matched blood is always preferable. If you don't have that, type unscreened. If you don't have that, type specific. And last, if you don't have any of that, O negative blood, which is the universal donor. And if you run out of O negative, you may have to switch to O positive, provided they have not had transfusions before, because RH incompatibility typically results in a delayed extravascular hemolysis as opposed to intravascular hemolysis. After about 4 or 5 units of packed cells, remember to implement a massive transfusion protocol where you're giving units of FFP and platelets to go along with the PRBCs. Multiple studies show better outcomes and decreased overall transfusion requirements if you keep up with the coagulopathy and transfuse packed cells and FFP in equal ratios with platelets ideally. Obviously, control any bleeding, either through tourniquets, pressure points, whatever you need to, ultimately surgical control. Avoid hypothermia because that will make any coagulopathy worse, and try to correct and treat acidosis. Hypothermia, bleeding, and acidosis is sort of the deadly triad of trauma. And then follow vital signs, urine output, cap refill, and lactate acid base levels as markers of resuscitation. Several studies basically have shown the best predictors of early mortality and shock are inability to reverse the acidosis and inability to clear lactate, because these are markers of anaerobic metabolism and inadequate perfusion. And if you can't correct that, obviously the patient is not going to do very well. So resuscitation efforts should focus on correcting the lactic acidosis and correcting the acid base status and maintaining a blood pressure that's adequate for perfusion. Now, in terms of infusion rates, this is what you can achieve both to gravity and with use of a pressure bag for different size catheters. So an 18 gauge gets you 50 mLs a minute, and obviously if you put the solution on a pressure bag, you do much better. You can get 150 mL per minute. 16 gauges, 100 to gravity and 225 to a pressure bag. 14 gauge, a little bit better, 150 and 275. And an A5 Cordis will get you 200 mLs per minute to gravity and 450 mLs per minute. The reason I bring this up is 216 gauge IVs on a pressure bag will get you the same flow rate as a Cordis on a pressure bag, and are going to be a lot simpler and a lot faster to place. So if you need rapid volume replacement, large, short peripheral IVs are going to be the way to go. Obviously, if you have the time or if you have one in place already, a Cordis can be helpful, but you can achieve very rapid rates with 16 gauges. They're easier to place than 14 gauges and probably are going to be the most bang for the buck in an emergent situation. In terms of automated infusion devices, the level 1, which is basically a heated system with large bore tubing and pressurized bags or containers for the fluid. No pump, passive system, will get you up to 1,500 mLs per minute with a cordis. And the Belmont, which is a heated, pressurized system with a pump, in theory can achieve 3 liters a minute through an adequately sized cordis, although the problem is the pressure alarm will trigger way before you ever achieve that. So in actual practice, you're probably unlikely to achieve these rates. So clinical scenario here. We have an 81-year-old nursing home resident who is brought to the emergency department for altered mental status. When she shows up, she is febrile to 39.4. She is hypotensive. She is tachycardic. Extremities are actually warm with hyperdynamic pulses and a widened pulse pressure. So given this history, what kind of shock do we think this is? Oh, everybody's muted. So this is a classic example of septic shock, where the patient probably had a UTI that went untreated at some point and became bacteremic, and she is now presenting an early septic shock.
No, they're putting it in the chat. It's coming up. Everyone's getting septic.
Gotcha. Yeah, these are not meant to be tricky. These are meant to be illustrative. None of these, other than septic shock, would be expected to result in fever. Of note, anaphylaxis, even though it involves the IgE, it is not an immune response per se and does not result in a febrile response. Neurogenic shock typically results in a cold patient because of vasodilation, and the rest of them have no direct effect. And again, this is sort of the classic hyperdynamic shock. So septic. This is the currently used definition of sepsis. It came from Sepsis 3 in 2016. And this is life-threatening organ dysfunction caused by a dysregulated host response to infection. So organ dysfunction is identified as an acute change in the total severity of illness assessment score greater than 2 points consequent to infection. If you don't have a pre-existing score, you assume that it's 0. And if it goes up more by 2 or more, then that reflects an overall mortality risk of about 10% in the general population with suspected infection. And if it goes up beyond 2, let's say 3 or 4, the mortality quickly approaches 40%. There used to be a category called severe sepsis before this definition came out. They purposefully did away with it because all sepsis is now considered an emergency and all sepsis is severe. So they felt that if people didn't classify sepsis as severe, they were lackadaisical about treatment, it delayed treatment, and it led to some of this persistently high mortality. This is the SOFA score, sequential organ failure assessment score. And it's divided up into respiration, coagulation, bilirubin, cardiovascular, i.e. hypotension, CNS, mental status changes, rising creatinine. And basically an increase of more than 2 from a baseline, which is assumed to be 0, buys you sepsis, and an increase of 4 buys you basically septic shock. Now, that's very complicated, and most people don't have that memorized and don't have ready access to it. So something that's a little bit more practical is the quick sepsis organ failure assessment score, or QSOFA score. This one only looks at 3 criteria: altered mental status, fast respiratory rate defined as more than 22 breaths a minute, and a low blood pressure defined as under 100. And this is in the setting of suspected infection or sepsis. There's a lot of things that can give you this, i.e. adrenal insufficiency or pancreatitis can give you this, but it's not necessarily sepsis. So if somebody has suspected infection, especially if they have a fever and they have 2 out of 3, then they have a positive Q-SOFA. So patients with more than 2 of these are significantly greater risk of having a prolonged ICU stay and dying in the hospital. And even though only 1 out of 4 infected patients have a Q-SOFA score of 2 or more, they account for 75% of deaths. So basically, these people should go to minimum of a step-down unit, if not an ICU. And obviously, if you're seeing one out in the field, they should be rapidly transported to a place that can do hemodynamic assessment, invasive monitoring, pressors, and treat shock. In terms of the pathogenesis, organisms or basically cell wall components lipoproteins elicit a systemic inflammatory response. And that in turn leads to diffuse endothelial damage and disruption of the endothelial junctions between capillary cells. You get inappropriate vasodilation, you get fluid leaking out of the endothelial junctions. So as a result of that, there is impaired perfusion of organs at the microvascular level. And eventually, with this refractory hypotension, multiple organ dysfunction, and the full-blown septic shock syndrome. And over time, there's progressive decrease in cardiac output, and this warm hyperdynamic shock will then turn into a hypodynamic, low forward flow, low perfusion pressure shock. So early on, hyperthermia or hypothermia, tachycardia, widened pulse pressure, low diastolic blood pressure. Invariably, because of the capillary leak and the distributive shock, there's hypotension, mental status changes, etc. And with this metabolically, invariably, there's an increase in lactate. And current recommendations are anyone with a lactate above 2 that does not respond promptly to fluid resuscitation should go to a step-down unit. And anybody with a lactate of above 4, again, which doesn't come down promptly with fluid resuscitation, should go to an ICU and is by definition in septic shock. Treatment, initially, adequate IV access and initially an IV fluid bolus. And the recommendation is 1 to 2 liters to start and then reassess hemodynamics. The patient probably will need more. The average resuscitation for a full-blown septic shock patient is probably going to be on the order of about 8 to 10 liters to give you an idea of the amount of fluid involved. If it's mild shock, a lot of times you can counter it with just fluids, but most people, more than 70%, are going to need pressors. And typically the one that's most recommended is norepinephrine to maintain adequate SVR and adequate perfusion pressure. And Society of Critical Care Medicine recommends keeping a MAP above 65 to make sure that you perfuse everything in this setting. Multiple papers have come out in the last year that show that norepinephrine is safe to run peripherally, and actual complications, even if the IVs infiltrate, are low. So don't delay, maintaining adequate hemodynamics to put an A line in. Don't delay for central line placement. Basically, normalize the hemodynamics as soon as you can, and then down the road, if you need to, and if the patient stays on pressors, especially escalating doses, you can put a central line in. But you don't want to delay for line access. The other thing is this is a medical emergency, and what's ultimately going to fix this, in addition to hemodynamic support, is appropriate antibiotic therapy. And basically, the estimate is that for every hour that you delay antibiotic therapy, mortality goes up 11%. And obviously, if there's more than a several-hour delay in starting antibiotics, then that patient is likely to die, even if they're started, if that therapy happens too late. Ideally, you want to get blood cultures prior to starting antibiotics, but again, you don't want to delay antibiotic therapy if it's going to take any significant amount of time to get cultures. If you don't know what you're dealing with, then vancomycin 1 gram, and Zosyn, which is piperacillin tazobactam at 3.375 grams IV, is a good broad spectrum antibiotic regimen that will cover most things in the immediate window. So moving on to a different patient, we have a 55-year-old male, diabetic, history of high blood pressure, who all of a sudden presents with crushing substernal chest pain and then very quickly becomes ashen, diaphoretic. He is now hypotensive, tachycardic. He stopped complaining of much of anything and has very cool clammy extremities. Do we think this patient is a shock? Yes. And what kind of shock is this? Let's see. I think I can see the chat, so I'm going to guess most people are going to point to cardiogenic shock as a cause. So this is somebody that's had enough ischemia to lose contractility to the point where they're no longer adequately perfusing. So cardiogenic shock is defined as a systolic blood pressure less than 90 with a cardiac index, and this is cardiac output divided by body surface area of less than 2.2 liters per minute per meter square. And this is in the setting of adequate filling pressure, defined as a pulmonary capillary wedge pressure if you have a swan in place less or greater than 18, which rules out a preload problem. So this basically cinches the diagnosis of a pump or forward flow problem. But again, if somebody has the right clinical setting, i.e. crushing substernal chest pain or significant cardiac history, they have bulging neck veins because blood is backing up since it's not flowing adequately. They have evidence of systemic poor perfusion. They have narrow pulse pressure. They have clamped down peripheral circulation. These are all reliable clinical signs that the patient is likely in cardiogenic shock. And again, cool mottled skin, hypotension, altered mental status, narrowed pulse pressure. If they lose enough pump flow, fluid is going to back up into the lungs. And at some point, you will have rales. You will have a dropping pulse ox, and they will start bringing up pink frothy fluid from pulmonary edema. And you may hear a new murmur with this, either from mitral valve disruption or a dysfunction, or an actual septal rupture if they infarct their septum. Common causes, the most common cause is significant ischemia or anterior MI. And again, acute loss of 40% of myocardium is enough to throw a patient into cardiogenic shock. The artery that's most likely to do this is obviously either the left main or the LAD. The LAD supplies the anterior wall and the anterior 2/3 of the septum, which is roughly 40% of the contractile element of the left ventricle. So if you acutely lose that, there's a high risk of progressing to acute cardiogenic shock. Arrhythmias, if they don't allow for adequate filling time or effective contractility, are an obvious cause of cardiogenic shock. And this can include everything from, let's say, a supraventricular tachycardia with a very fast rate to ventricular tachycardia, ventricular fibrillation, any arrhythmia, which basically you lose the ability to pump blood efficiently. Trauma, you can see cardiogenic shock with myocardial contusions, and you can sometimes see this with rapidly progressive viral myocarditis. And, you know, arrhythmias, obviously you're already there, but all of these conditions also have a very high risk of degenerating suddenly into VTAC or ventricular fibrillation and the patient coding. And then last, you can see this picture with late untreated sepsis. So initially, you're hyperdynamic and warm. If sepsis is allowed to persist, you get worsening myocardial depression. In fact, if you do an echo in somebody that's in classic sepsis or induced vasoactive pressure requirements. The average EF that you'll see on an echo at that time is about 30-35%. And that happens in almost all patients and recovers as basically they recover from their sepsis syndrome. If allowed to progress, that myocardial decrease in contractility worsens, and at some point it starts resembling cardiogenic shock, and at that point it's probably in the irreversible phase. The last one on here is acute aortic insufficiency or aortic dissection and tamponade. So if somebody, let's say a drug user, blows out their aortic valve, acute severe aortic insufficiency is tolerated very poorly, and they very rapidly go into pulmonary edema and CHF without acute surgical intervention. Talked about this. So obviously, if you suspect ischemia, an EKG a lot of times will show the diagnosis. A chest X-ray is useful for assessing pulmonary edema, for assessing cardiac size in terms of figuring out if somebody's in tamponade, if they have chronic CHF and chronic reduced heart function. It will show you aortic dissection or aortic enlargement sometimes. Labs to get: coagulation studies, cardiac enzymes, chemistry, CBC. And then an echocardiogram is invaluable because it will show you decrement in contractility or lack of contractility for an MI and give you an overall estimate of the current EF at that point in time. And if you have the ability to do a fast exam, and especially if you have portable echo, you can get a peristernal or a subxiphoid view in 5 seconds and get an idea of what the patient squeezes and what their heart is doing. Treatment. If they're going into pulmonary edema, obviously you're going to want to intubate the patient and give extra oxygen and PEEP as needed to oxygenate them. The other thing is if the patient's hypotensive and in shock, intubation and positive pressure ventilation actually offloads the left ventricle and drops the afterload on it and actually decreases the oxygen requirement of the LV. And it does that because the increase in intrathoracic pressure drops the transmural pressure across the aorta and drops the afterload that the left ventricle is pumping in, because that change in pressure from inside the ventricle to outside is part of the impedance of the heart. So raising the intrathoracic pressure, let's say from 0 to 10 to 15 centimeters of water, is a lot less than the 70, 80, 90, 100 millimeters of mercury that they're pumping at. So it doesn't actually obstruct the pumping mechanism of the heart, but drops the afterload. So it's actually beneficial for LV dysfunction. If they're in cardiogenic shock, you are going to have to augment their perfusion. And dobutamine is sort of the drug of choice, although by itself is a vasodilator, and we may need supplementation with norepinephrine to maintain an acceptable SVR and an acceptable blood pressure for perfusion. If they're really sick and dobutamine doesn't do it, epinephrine becomes your best inotrope for trying to maintain forward flow. Obviously, both of these drugs are going to increase myocardial oxygen consumption, epi more than dobutamine, but the bottom line is you have to perfuse, otherwise the patient's not going to survive. And if you're not able to achieve that otherwise, you're going to have to put the patient on inotropes to try to maintain them long enough to be able to correct whatever cause of cardiogenic shock is there, be it ischemia, be it something else. In somebody with poor contractility, you want just enough blood pressure to perfuse things with a low afterload. I.e., you don't want to, let's say, put this patient on phenylephrine or high-dose norepinephrine and raise their blood pressure up to 120 by peripherally vasoconstricting them. They're already unable to pump well at the afterload they have, and cardiogenic shock is inadequate forward flow by definition. So the problem is if you excessively vasoconstrict them, the blood pressure will go up, but you're going to have even less forward flow, and you're going to have even more tissue ischemia and a worsening acidosis. So the idea here is just enough systolic blood pressure to give you an adequate perfusion pressure with as much of a low SVR as possible to perfuse at that blood pressure. So dobutamine is a good drug for doing this because it basically stimulates beta 1 receptors, which increases contractility and gives you some vasodilation through the beta 2s. Low dose epi will do the same. Again, norepi will increase contractility, but by itself tends to raise systemic vascular resistance too much. Phenylephrine would be a bad drug in this setting, as would vasopressin. And then the other thing is be careful with fluids. So if somebody's hypotensive, the tendency is to turn up the fluids and give them fluid. And the problem here is if they have impaired contractility, then if you give them too much fluid, two things will happen. One, you'll push them over the edge of the Frank-Starling curve because they're not able to increase contractility to respond to the increased preload. And they're going to end up on the descending loop of that Frank-Starling curve. The other thing that happens is if they're not able to pump the extra fluid forward, you're going to distend and stretch out the left ventricle, which in turn will work to increase the wall tension on that ventricle, which in turn will greatly increase myocardial oxygen consumption, which will make the ischemia worse. So if they needed a little bit of preload, but for the most part, try to avoid fluids if it's cardiogenic shock. You're going to have to support them with some sort of inotrope and trying to manage afterload as best as you can. The main reason that nitroglycerin tends to terminate ischemia very quickly is not because it's a coronary vasodilator, but because it's a venodilator and gets to an acute drop in preload. And that's usually what decreases oxygen tension and decreases oxygen consumption. The coronary vasodilation is an added benefit, but that tends to have less impact than the acute drop in preload from venodilation. This is also why morphine is the recommended narcotic of choice for treating pain, because it releases histamine and acts as a venodilator and acutely drops preload, whereas fentanyl or some of the other narcotics will not do that. The other drug the cardiologists love to throw in if somebody's having ischemia and angina is Lasix, again, because it's a venodilator. And they typically will drop somebody to a systolic blood pressure of about 100 to try to manage the anginal symptoms. You don't want to go less than that because then you're not perfusing for obstructive coronaries. I'm sorry, come in. And then last, ultimately, what's going to fix this if it's ischemia, this is either an MI or an unstable plaque, is going to be a percutaneous intervention receiving center, i.e. a cath lab. And normally the AHA standard is 90 minutes from door to balloon, and add another up to 30 minutes in that for transport. So basically the standard, if you will, is from first responder medical contact to PCI 2 hours or less. And if you can get it under that, even better. Okay. But they give you guys 30 minutes to get them to the center, and then the center has 90 minutes from when they hit the door to get them to a cath lab if they need one. They get 20 minutes to basically admit the patient, get an EKG, and make the diagnosis. They get another 10 minutes to notify the cath lab, and then the cath lab has 30 minutes to get spun up and take the patient in. In terms of medications that you can use to treat, this is more in terms for angina and MI than cardiogenic shock. But aspirin and beta blockers have direct mortality benefit in ischemic heart disease. Aspirin being the most significant, 22% reduction in mortality in ISIS 2. So anybody that basically has ischemia or ischemic symptoms should get aspirin as quickly as possible. If they can take it orally, great. If not rectal, it should be at least 160 milligrams, and ideally it should be chewed to be absorbed as rapidly as possible. If we think it's an MI, then typically the patient should be put on heparin to stabilize the clot. Low molecular weight heparin, Lovenox at 1 mg per kg in twice daily dosing is preferred, but if not, unfractionated heparin weight-based is perfectly acceptable. If the patient is stable and they have the blood pressure for it, then you could consider a beta blocker and nitroglycerin. But obviously, if the patient is in cardiogenic shock, they should not get anything that has the potential to lower blood pressure or decrease contractility. If there's no pulmonary edema and they're hypotensive, you could consider a careful small IV fluid challenge. But again, be careful if they're ischemic because you may increase their oxygen demand and make the ischemia worse. If the patient is in pulmonary edema, so things that will help immediately are going to be intubation, positive pressure, and PEEP potentially, which also helps to offload the left ventricle. Drugs that acutely cause pulmonary vasodilation may be helpful in terms of dropping the hydrostatic pressure and helping them resorb some of that fluid and minimize the fluid translocation. So nitroglycerin is a very good pulmonary vasodilator. Lasix is a good pulmonary vasodilator, but again, the problem with all of these is they tend to drop systemic blood pressure, so if the patient is in cardiogenic shock, are going to be contraindicated. And then last, you're going to want drugs to increase contractility and help them pump fluid forward to clear their fluid out of the lungs. The best combo is probably going to be dobutamine as an inotrope and norepinephrine as a secondary inotrope, and to prevent the hypotension that you're likely to see with dobutamine. And then ultimately, percutaneous intervention, if you can get them to a cath lab. If you can't get them there, the next best thing is going to be TPA and IV thrombolytics, with the caveat that if they fail that, then they're going to have to go to a cath lab anyway. The right ventricle is much more difficult to infarct than the left ventricle. And the reason for that is that it's a low pressure system. So left ventricular systolic blood pressure equals systemic blood pressure, which is 100 to 120 millimeters of mercury, meaning that the left ventricle gets no perfusion during systole and gets all of its perfusion during diastole. The right ventricle, if you don't have pulmonary hypertension, typically achieves a systolic blood pressure of about 30 to 35. And since systemic blood pressure is 100 to 120 systolic blood pressure, that means the right ventricle is perfused during both systole and diastole. So because of that, it's much more resistant to ischemia. But with posterior descending artery or right coronary infarcts, you may see an RV infarct. And typically you'll see ST elevation or ST depressions anteriorly. And if you want a diagnosis, you can get a right-sided EKG where you put your anterior leads over the right chest wall as opposed to the left, and it will show up. The important thing here is because the RV is not working, they are very, very sensitive to changes in preload. So you want to be very careful giving drugs that cause immediate venodilation, i.e. nitroglycerin, because the RV will not fill. And since it can't pump, that means the LV will not fill, and you will have very rapid hemodynamic collapse. By the same token, fluid is going to be important to try to force fluid across that right ventricle to the left to provide adequate systemic preload. But if you give too much too quickly, you're simply going to overdistend the RV more, and it's going to fail entirely. So some, but not too much fluid, dobutamine, and minimize or avoid any use of venodilators. The other thing is mechanical ventilation and positive pressure ventilation will worsen RV function, unlike the left ventricle. And again, this is due to the fact that the RV is a low pressure pumping chamber. So here, acutely increasing the pressure in the chest from 0 or the -5 or -10 that we breathe at to 10, 15 centimeters of water will decrease RV forward flow and RV output. So positive pressure ventilation is good for LV failure, bad for RV failure. If you have acute mitral regurg or an acute rupture of the septum and an acute VSD, the patient is going to go into CHF very rapidly. And unless they're in close proximity to a cardiac surgeon and able to go to the OR quickly, they probably will not survive. But the goal is to try to keep them alive long enough to do that. So basically what you need here is inotropes, i.e. dobutamine, vasodilators. So probably nitroprusside would be the drug of choice. Nicardipine is readily available, but it's too much of a water and salt load in the setting for anything more than very short-term use. Clofidipine is another possibility. But basically, you want to increase contractility and drop afterload as much as you can to minimize the backwards flow through that mitral valve or through that VSD and enhance forward flow, and hope that they can hang on with a systemic of 70 or 80 long enough to get to a cardiac surgeon. Next, different type of shock. So we have a 34-year-old woman who presents to the ER by EMS. She was dining at a restaurant. She ate a few bites of her meal and all of a sudden became anxious, diaphoretic, started wheezing, developed a diffuse rash, nausea, and then she had a sensation of her throat closing off. And she is currently very hypotensive, tachycardic, and ill appearing. So what do we think this is? If you said anaphylactic, you are correct. So anaphylaxis is defined as severe systemic hypersensitivity reaction characterized by multisystem involvement, which is immunoglobulin E mediated. So part of what you get with this is you get massive activation and degranulation of mast cells, release of histamine, and basically other inflammatory mediators, and you will get massive vasodilation, massive capillary leak, and a systemic inflammatory response, activation of complement, all of which can be rapidly fatal. We used to distinguish anaphylactoid reactions from anaphylaxis. We no longer have that. What we have now is non-IgE mediated anaphylaxis. And this is basically the same syndrome, except that in this case, it is not mediated by IgE, and as a result, typically does not require an initial sensitizing exposure. And the classic example of non-IgE shock or anaphylactic shock or anaphylaxis is IV contrast. You can develop it the first time you ever get contrast. You may get it the next time you get contrast, you may not. You may get a more severe reaction, you may get a less severe reaction. It's variable, but it does not result from sensitization, memory cells, or prior exposure. Whereas, let's say, an antibiotic allergy or a bee sting allergy requires prior exposure where you got sensitized, and then massive release of immunoglobulin E from activation of those memory cells. Symptoms of anaphylaxis. It's going to vary basically by where the allergen enters the body. But yeah, systemic symptoms are going to be classically hives and or flushing. You may have a sensation of impending doom, severe anxiety. The patient may experience throat fullness or a lump in the throat, shortness of breath and chest tightness. And then finally, they're going to have altered mental status, respiratory distress, and ultimately circulatory collapse. If they're intubated in an ICU or if in the OR, typically you're obviously not going to have any complaints. And you may not see skin manifestations. What you're going to see is sudden cardiovascular collapse, and it becomes a challenge to figure out what the cause is. Risk factors for fatal anaphylaxis. Who is going to do poorly and who you should worry about? Asthmatics are at increased risk of anaphylaxis, and poorly controlled asthmatics are at specifically increased risk of sudden respiratory obstruction and arrest with anaphylactic events and are more prone to them. Anybody that's had previous anaphylaxis is at increased risk in the future and is also a risk of severe reactions. Anybody that has a history of atopic dermatitis because they have an altered T cell, CD4, CD8 activation and are more likely to react. And then of note, patients that are on beta blockers or ACE inhibitors tend to have much more severe anaphylactic events, and they tend to be much harder to treat when they occur because they block the compensatory pathways, which are the sympathetic nervous system and the renin-angiotensin-aldosterone pathway. Common causes, antibiotics tend to be very common offenders. Nut allergies are the most common ingested allergens and can cause the most severe reactions, followed by milk products. Hymenoptera stings, people that are allergic to wasps, bees, ants, etc. And then latex has been an increasing cause of anaphylaxis, both in the hospital and out of the hospital. Severe reactions usually will start within 60 minutes of exposure, and the faster the onset of symptoms, the more severe the reaction. So somebody that ingests, let's say, peanut oil or gets stung by a bee and immediately breaks out in hives, watch out because that person is much more likely to progress to full-blown anaphylactic shock. But even mild symptoms can progress over time. Anybody that complains of a lump in their throat or hoarseness, intubate that patient sooner rather than later and keep a very low threshold for doing so, because that basically signifies laryngeal edema, and that can progress very quickly to obstruction and to an airway that's impossible to obtain. So if there's any doubt about their airway, then have a low threshold to intubate them and take the tube out later if you're wrong. Another important concept on anaphylaxis is that up to 20% of patients will have a biphasic phenomenon and or persistent anaphylaxis. What I mean by this is they'll get symptoms, they'll get treated, things will improve, they'll feel a lot better, only to have the symptoms come back, sometimes in even worse form, in 3 to 4 hours. And as a result of this, anybody that has anaphylaxis should be, even regardless how quickly they're recovered, should be observed for a minimum of 6 hours before they're discharged and should be brought in. And ultimately, this is a clinical diagnosis. Labs have no initial role. There's only one lab that can confirm anaphylaxis, which is mast beta cell tryptase, which is a very specialized test that takes several weeks to come back. Histamine levels are meaningless because they're very short-lived, and even something as simple as sticking a needle through the skin of a vein, into a vein will release enough local histamine to get to an elevated level. So in terms of treatment, again, airway, breathing first. So angioedema, evidence of respiratory compromise, swelling of the mouth and lips, lump in throat, etc. All of those things tend to indicate need for immediate intubation. The other thing is they're going to need IV fluid. When I say that they get an inflammatory response and they get sequester fluid, a full-blown anaphylactic event, they can sequester half their blood volume within 30 minutes. So large bore IVs and lots of fluid. And a full-blown event, expect to have to give about 4 to 5 liters of fluid to try to restore adequate intravascular filling volume. And then the drug that's ultimately going to fix this, and the sooner you get it in, the better, is epinephrine. And epinephrine has a specific benefit in terms of stabilizing mast cells and basophils and inhibiting further release of inflammatory mediators and stopping that inflammatory cascade. So the dose of choice is 0.3 milligrams or 300 micrograms IM of the 1 to 1,000 1 cc vial, or 10 to 20 micrograms at a time IV till they stabilize, and then put on an infusion if giving IV. And if you're using IM doses, be prepared to repeat that every 5 to 10 minutes till the reaction is brought under control. Now, people on beta blockers, especially higher dose beta blockers, the epinephrine is going to have an attenuated effect because of the beta blockade. And the other problem is that you can see unopposed alpha activation with higher doses of epinephrine without seeing the beta effect and severe hypertension. So for these people, you may have to give higher doses. The other thing is vasopressin becomes a very good second drug if you're not getting a decent response, especially if they're on ACE inhibitors or beta blockers. If they're in true cardiovascular collapse, then you are moving on to ACLS doses where you're giving a milligram at a time IV. And if they're refractory, in addition to the IV bolus, you're going to start a drip, start at a mic per minute, and escalate as needed to maintain a reasonable blood pressure, ideally a MAP of at least 60 to 65. And I'll show you guys some data, but any delay in giving epinephrine significantly raises mortality. Other drugs available, and again, especially handy if somebody's on beta blockers or ACE inhibitors, vasopressin is good for refractory hypotension, 1 to 2 units IV at a time, and you can give up to 20 units for collapse that's unresponsible to epinephrine. And then the other one that's useful, and again, especially useful for people on beta blockers, is glucagon, because it activates adenyl cyclase and the adrenergic pathway through a non-beta agonist receptor. So it bypasses that beta blockade. And the treatment here is 1 milligram IV every 5 minutes till the hypotension resolves, and then start a drip if needed. Other drugs that are beneficial, again, the primary treatment is going to be epinephrine, but patients should get corticosteroids. Now, corticosteroids take an hour to work because they alter nuclear protein translation. So they don't have an immediate benefit for stopping the reaction, but what they do is they prevent recurrent anaphylaxis and they prolong those persistent reactions. So it's important to get those on board. And likewise, both H1 and H2 receptors mediate hypotension. So you want to give the patient both an H1 and H2 blocker. And then if you have severe bronchoconstriction, in addition to the epinephrine, you can do nebulized beta-2 agonists such as albuterol, and magnesium, especially in higher doses, is useful as a bronchodilator, with the added caveat that it also causes vasodilation. So don't use it unless you have to if the patient is hypotensive. Now, I talked about delaying epinephrine and how that leads to mortality. So this was an early dog model where they induced anaphylaxis in ragweed sensitized dogs and looked at timing of epinephrine, both IV and IM. And what they found is that once cardiovascular collapse was fully developed, even IV epinephrine in full doses failed to reverse the cascade, and those patients entered a reversible phase of shock and they died. Similar study, this time looking at children that anaphylaxed to food, all of which had known food allergies, therefore they were sure as to what the source was. And 13 kids, 6 were fatal, 7 were non-fatal. Of note, the kids that survived, all of them got epinephrine within 30 minutes. The kids that didn't survive, only 2 had epinephrine in the first hour at 25 to 60 minutes. The rest of them, it wasn't until later that they thought of anaphylaxis as the cause. And by that point, it was too late to reverse the cascade. So since you want to get epinephrine in quickly, this is a study looking at healthy young men and blood levels and systemic absorption with sub-Q and IM injection, also the site of injection. And basically what I want to point out is that thigh injections as opposed to deltoid injections down here, get you much more rapid absorption, much higher peak levels, much faster. And by comparison, arm injections and sub-Q injections don't really get you a peak effect and get you much lower levels. So if somebody's having a severe response, the treatment is going to be 0.3 milligrams of epinephrine IM anterior thigh, as opposed to the deltoid, repeated every 3 to 5 minutes. And if you have IV access, an epinephrine drip. Arm injections are going to be much less effective for absorption. Oh, sorry. Again, because of the risk of recurrent or late anaphylaxis, anybody who is sick enough to get epinephrine should be brought in and observed for 4 to 6 hours, at which point, if they're symptom-free, then they're out of the woods and they can go home. Anybody who is on beta blockers or had a severe reaction in the past gets admitted overnight on telemetry because they're more likely to recur and have a bad reaction. To further sort of emphasize that it's important to get epinephrine in early, this was a study looking at 21 or anaphylaxis in the operating room. And what they found, even with current knowledge and all the current drugs and methods we have available, perioperative anaphylaxis to this day still carries a mortality rate of 4%, with 2% of people surviving but with severe brain damage. And this is in the operating room with monitors, ready IV access, and a anesthesiologist or anesthesia provider at the bedside. And why is the mortality still 4% in this setting? The problem is people don't think of anaphylaxis necessarily. And this was a study that was part of that, where Jacobson looked at 21 pairs of anesthesiologists in an anesthesia sim center. And the problem is that, again, anaphylaxis in the OR presents as sudden cardiovascular collapse. And it's hard to come up with anaphylaxis as the cause of that in that setting, given the number of possibilities. So the problem is, even at 10 minutes out, none of the teams could identify correctly the diagnosis. And at 15 minutes, with some hints, only 6 of 21 teams considered the correct diagnosis. So the rest of them, 30 minutes, an hour longer before they thought of it and gave epinephrine. And the problem is, if you delay, at that point, it becomes irreversible. So if somebody doesn't have sort of the classic hives or the classic presentation, the most important thing on anaphylaxis is to think of it. Different kind of shock is neurogenic shock. And this you see after acute cord injury. And this happens because when the cord is transected or acutely damaged, the patient goes in what's called spinal shock, which is basically loss of all spinal activity below the level of that injury. And that can last anywhere from a couple of hours to a couple of days to up to 2 to 3 weeks. And with that, there's immediate vasodilation of everything below that cord level. So if this occurs high, then that's enough vasodilation to put the patient into shock. And if it's high enough to involve the cardiac sympathetics at T1 through T4, then you will not see sympathetic cardiac compensation, and there'll be an appropriately bradycardic in addition to being hypotensive. And that hypotension will be markedly accentuated by postural changes because they don't have the autonomics to compensate. So treatment here, again, airway, breathing, circulation. If it's a high injury, and especially if it's above C6, it will involve the output to the phrenic nerve. They will be unable to cough to clear secretions. So pretty much almost all of those patients are going to need intubation initially. They may come off the ventilator with some time and with some adjustment or with some training, but at least initially, they likely will need airway support. The other consideration is for any sort of acute cord injury, one of the cornerstones of treatment is adequate perfusion. And the goal is usually to keep the blood pressure at upwards of 85 initially for the first 7 days to maximize recovery of the penumbra. Debatable as to whether this works or not. The last study showed that it doesn't really work well, but since we don't have a lot of effective treatment for cord injuries, this is still the standard of care. So as a result of this, and especially given they're likely to be hypotensive, these patients are usually going to end up on pressors to try to maintain adequate perfusion. Because it's a form of distributive shock, they will need fluid replacement, but be careful with fluids because they're also going to be at high risk for pulmonary edema because they can't increase contractility and they can't increase heart rate to compensate for an acute increase in preload because they lack the sympathetics to do so. So some fluid, but not too much fluid. If you have a CVP, a goal of 15 or so is probably good in this setting. And then the drug of choice is going to be norepinephrine. You can also consider dopamine if they're inappropriately bradycardic as another way to chemically increase the heart rate to try to maintain perfusion. And unless a neurosurgeon says otherwise, the initial goal is going to be a MAP above 85. Drugs like atropine, and obviously if you need a transthoracic pacing will work, but usually dopamine is going to be a good drug to increase heart rate if they need that. Let's see, let's wrap up here. Last, we have extracardiac obstructive forms of shock. So this is a 24-year-old got in a car wreck, now has chest pain, difficulty breathing. He is tachycardic, hypotensive, hypoxic, and has decreased breath sounds on the left. So this is an obstructive form of shock. Any guess as to what the cause may be? So probable tension pneumothorax, right? So these are all important because if you don't identify them, they're fatal. And if you do identify them, the treatment a lot of times is relatively straightforward. So a tension pneumothorax results when you end up with a one-way valve mechanism in the lung, which lets air in but doesn't let air out. So whatever pneumothorax you have there progressively expands. Over time, it will increase intrathoracic pressure, and that in turn will lead to cardiovascular collapse. And the important thing here is it's not the airway impediment that kills these people, it's the cardiovascular collapse. Because that increase in intrathoracic pressure opposes venous return, meaning you have to have a CVP above that to allow any cardiac preload. So if intrathoracic pressure rises enough, cardiac preload and filling stops, heart runs empty, and you have cardiovascular collapse. So basically, this is an emergency. You don't really have time for a chest X-ray. And if you suspect this, the treatment of choice is going to be a needle decompression, large bore needle or a 14-gauge angiocatheter, second intercostal space, mid-clavicular line, basically straight in to decompress that pneumo. That will turn a tension pneumo into a simple pneumothorax. If you didn't have a pneumothorax before, you will after this. So invariably, the patient will need a chest tube after this procedure. But a simple pneumothorax by itself is not an emergency, whereas a tension pneumothorax is. Another one to think of is cardiac tamponade, especially with blunt chest trauma or myocardial contusion. You may also see it with pericarditis, although that's usually more slowly developing. It comes with a classic triad of hypotension, jugular venous distension, and muffled heart sounds, but less than 30% of patients are going to show the classic Beck's triad. Typically, what you're going to have is hypotension. They're going to have orthopnea and inability to lay flat for whatever reason. They'll have muffled heart sounds and basically a mechanism that leads you to suspect pericardial tamponade. And if you have time for an echo or a chest X-ray to confirm the diagnosis, great. If not, the treatment is going to be subxiphoid needle decompression to drain enough fluid to allow them to maintain output. The other temporizing measures are going to be fluid to increase preload, to allow the heart to fill, with this increasing extracardiac pressure in the pericardial sac, and inotropes, norepi, to maintain systemic pressure and perfusion with a decreased preload. And then the last common cause is pulmonary embolus, which is going to show up with tachypnea, tachycardia, hypoxia. On echo, if you have it, you will classically see a D-shaped septum as the distended right ventricle pushes in on the left ventricle. In terms of lab work, if they're not a trauma or a surgical patient, an elevated D-dimer can help confirm the diagnosis. The bottom line is you don't have a ready fix for this. So the treatment of choice for this is going to be thrombolytics or a trip to the cath lab for a pulmonary embolectomy if feasible. But if not, then supportive care and hope they get through it. And the treatment is going to be fluids and norepinephrine to maintain contractility and perfusion, similar to the other forms of extracardiac obstructive shock. People who die of a pulmonary embolus invariably die of it within the first hour, because either they have enough cardiac reserve left afterwards to maintain perfusion or they don't. And usually with a massive P, the hemodynamic compensation is sudden. If they survive that first 10, 15 minutes, they're probably going to survive the event. Heparin does not dissolve or treat the clot. Thrombolytics do that. Heparin simply stabilizes the clot and prevents them from flipping up the next pulmonary embolus from their deep venous thrombosis, which then risks basically taking out enough surface area to render them unstable. But if they survive the initial event, they're probably going to survive the pulmonary embolus. Again, treatment here is airway, breathing, circulation, oxygen delivery, and figure out and achieve your endpoints of resuscitation. And these are goals for treatment of any form of shock and basically any significant derangement. For septic shock, the MAP that's recommended is 65, and that is probably a reasonable MAP goal for most forms of shock to ensure adequate perfusion, with the exception of neurogenic shock caused by cord injury, where if they have the cardiovascular reserve, ideally you want to have a MAP of at least 85 initially to maximize recovery of damaged but not dead cord. Remember that intubation will drop afterload on the LV and help LV function, but will decrease preload and worsen hypotension. And if you induce somebody that is severely hypotensive, i.e. hemorrhagic shock, you can decompensate them and kill them very rapidly. Because one, all the drugs are myocardial depressants. They all tend to be vasodilators, which further drop preload, and then that acute change from negative to positive pressure ventilation will also additionally decrease preload. So if you have somebody who is very marginal from a cardiovascular standpoint, delay intubation, gently bag them if you need to, long enough to support them, raise the preload to some sort of satisfactory level, and then induce them with a drug such as ketamine, which supports sympathetics, or etomidate, which causes less vasodilation than propofol. But even those drugs are going to take away intrinsic catecholamines and risk killing somebody that is, severely decompensated. The other thing is, even if somebody is not in imminent respiratory failure, they're not going to be far off if they're in decompensated or untreated shock. Because one of the things they're not going to perfuse very well is those respiratory muscles, which consume a significant amount of oxygen. And as they lose the ability to perfuse, they're going to shift their blood flow and perfusion centrally to the heart and to the brain and sacrifice those respiratory muscles, which are going to run out of blood and out of oxygen and suddenly quit. The other thing is, if you have limited cardiac output and limited oxygen delivery, You want to rest those respiratory muscles to decrease their oxygen requirements so they generate less lactate and allows you to use the perfusion that you do have on more vital things. So for all those reasons, in decompensated shock, intubation is a good thing, provided they have the hemodynamics to cope with that initial induction and intubation. We talked about circulation. So, you typically will not have a central venous line. But if you do, you want to aim for 8 to 12. If you don't have it, give 1 liter to 2 initially and reassess where things are at, with the exception of cardiogenic shock, especially if you have jugular venous distension, rails, or other evidence of fluid backing up in the system, where you want to limit giving additional fluid. For sepsis, for anaphylaxis, then, initial 2 liters is a good starting point, but expect to have to give at least 4 and usually upwards of 6 liters of fluid to resuscitate somebody. So you typically will have to repeat those fluid boluses. Obviously, for hemorrhagic shock, till you stop the hemorrhage, all bets are off in terms of the amount of fluid that you're going to need. If they're bleeding and if they're anemic, maintain a crit of at least 24. And if you can't correct the shock state, regardless of what it is, and you have evidence of inadequate delivery, then you want to get the hemoglobin to at least 8 to maximize the oxygen carrying capacity. Colloids you can consider. Remember that they're more viscous, takes longer to get in, and there's no proven outcome benefit for anything short of liver failure and albumin deficiency. Let's see. Sorry, I didn't take out the transitions in this. Another useful thing, if you are unable to register a blood pressure or a pulse ox, and you want to quickly feel where somebody's at, if you can feel a carotid pulse, they have a systolic blood pressure of at least 60, and at least imminently, that's enough to perfuse the brain at that point in time. If you feel a femoral pulse, they have a systolic of at least 70. And if you feel a distal pulse, either radial or dorsalis pedis, they have a systolic of at least 80. They're probably still in shock if you have the other clinical evidence of it, but they have some perfusion pressure and are getting some blood flow to their brain and heart. So, summary slide for hypovolemic shock. Fluids, blood products, Levophed to stabilize them till you get the fluids and blood products on board. And then for anything that's significant enough to be in a shock state, if bleeding is the cause, probably early surgical intervention to stabilize them. For cardiogenic shock, avoid too much fluid. Dobutamine plus usually Levophed plus or minus epinephrine, depending on how bad they are. And then basically rapid transport to a cath lab or revascularization center. For sepsis, fluid, Levophed, and antibiotics. For neurogenic, Levophed with ideally a MAP target more than 85 and cautious fluid. For anaphylaxis, lots of fluid and early epinephrine. And then for obstructive shock, it depends on the cause. For pediatric shock states, commonly used drugs are going to be dopamine, epinephrine, and norepinephrine at the doses that are on there. And especially in kids, if you have trouble getting IV access, then remember you can give blood, you can give fluid, you can give your vasoactives, true and intraosseous infusion till you can get something better. Serial lactate levels, if you can get them. That's your best indicator that you're no longer in anaerobic metabolism. So basically, the sooner you clear that, the sooner you will decrease the mortality. So check them at least hourly based on your interventions. Let's see. If you're not able to reverse things and you have persistent hypotension, things to consider. Could be something simple as you simply haven't given enough fluid yet. Again, for a septic shock or anaphylaxis, it may take 8 to 10 liters of fluid. If you've only given 2 or 3, the patient's still going to be hypotensive. You have hidden bleeding. You have ongoing bleeding into the chest, into the retroperitoneum, out on the floor that you're missing somewhere, but something is still bleeding. You have a pneumothorax, which has become a tension pneumothorax. One point on pneumothoraces. A pneumothorax in a spontaneously breathing patient has a low chance of becoming a tension pneumothorax. If you intubate that patient and put them on positive pressure, there's a 50% chance a simple pneumothorax will become a tension pneumothorax. So mechanical ventilation, trip to the OR, et cetera, all of these become indications for chest tube placement, even if somebody has a small pneumothorax, because it can rapidly get worse. So if the patient has a pneumothorax and no tension physiology yet, and you intubate them, keep an eye on that, especially if you get hemodynamic decompensation, low threshold needle decompress them. Cardiac tamponade, allergic reactions, especially to medications, and especially if things aren't getting better and you haven't given epinephrine yet. And then last, consider things like adrenal or thyroid insufficiency. Adrenal insufficiency is an ultimately fatal condition and will show up as a distributive shock, which will be poorly responsive to fluid and pressors till you correct the underlying problem. But these are some of the causes of persistent hypotension. And that's probably enough for one sitting. Let's open it up to questions.